all eminent faculty members and participants who have joined from various parts of India and abroad. Welcome to this live webinar. I am Sumit Kumar Madan from Zydus Life Sciences Limited, and on behalf of Zydus, I welcome our guest speaker, Dr. Maria Diaz Camelo, our today's chief guest, Dr. Riaz Ahmed, all discussants and participants to this virtual symposium on novel drugs in MDS. Before we commence the proceedings, I would like to welcome and introduce the host and convener for this webinar under the aegis of Mumbai Hematology Group, Dr. Amit Khurana. Dr. Amit Khurana is a well-respected and humble senior hematologist and bone marrow transplant physician from Surat in Gujarat. I request Dr. Amit Khurana to navigate this program further. Sir, over to you.
Thank you, Mr. Sumit Kumar. Let me share the screen. So very good morning to all of you, and good afternoon and good evening to all others who are joining from rest part of the world. Today, our guest speaker for the day is Dr. Maria Diaz Campello from Spain, and she's going to lecture us on novel drugs in MDS. This webinar is brought to you by Mumbai Hematology Group, supported by Zydus, dedicated to life, and managed by Perfect Square. I thank Mr. Ashish Kumar, Mr. Sumit Madan, and Team Zydus, Mr. Yash, Mr. Kalpesh, and the Team Perfect Square, Executive Committee of Mumbai Hematology Group, our chief guest for the day, Dr. Riaz Ahmed from Delhi, our guest speaker for the day, Dr. Maria Diaz Campello from Spain, all our discussants who are themselves very eminent hematologists and hemato-oncologists, and you participants for sparing the Sunday morning, afternoon, and evening from whichever part of the world you've logged in. Let me give you a flavor of our next weekend activities. Next Saturday, that is 4th of May 2024, from 7 p.m. Indian Standard Time and 8:30 a.m. Central Time, we have webinar on challenges in histopathologic diagnosis of Erdheim-Chester disease by our guest speakers, namely Dr. Karen L. Rech and Dr. Grace Genu Whiting from Minnesota, USA. And the following date, it is Sunday, 5th of May 2024, from 11:30 a.m. Indian Standard Time and 2 p.m. Singapore time, we have our guest speaker, Dr. Chandramouli Nagarajan from National Cancer Center, Singapore, speaking to us on multiple myeloma maintenance therapy in 2024. Let me introduce our discussions for the day, and here displayed in alphabetical order. To start with, we have Dr. Aditya Jandial from Homi Bhabha Cancer Hospital and Research Center, Mulanpur, Punjab. Dr. Akanksha Garg from Zydus Hospitals and Zydus Cancer Center, Ahmedabad. Dr. Deep Gala from SGPGI, Lucknow. Dr. Fahima Hassan from United Institute of Medical Sciences, Prayagraj. Dr. Kripa Bajaj from Basavatrakam Indo-American Cancer Hospital and Research Institute, Hyderabad. Dr. Mona Vijayaran from SGPGI, Lucknow. Dr. Nihar Desai from LTM Medical College and LTMG Hospital, Sion, Mumbai. Dr. Pujita Bai Reddy from CARE Hospitals, Hyderabad. Dr. Pradeep K. Reddy from PGI, Chandigarh. Dr. Rizwan Akhtar from SGPGI, Lucknow. Dr. Sadashivadu Gundeti from Nizam's Institute of Medical Sciences, Hyderabad. Dr. Stelin Chaudhary Bala from Mahatma Gandhi Cancer Hospital and Research Institute, Visakhapatnam. Dr. Swati Sinha from King George Medical University, Lucknow. Dr. Upendra Sharma from Bhagwan Mahavir Cancer Hospital, Jaipur. Dr. Urmimala Bhattacharjee from Barts Health NHS Trust, London. Dr. Vikas Talreja from Regency Hospital, Kanpur. Now is the time to introduce our very special guest for the day. We have with us our chief guest, Dr. Riaz Ahmed. Dr. Riaz Ahmed is MD, DM in Clinical Hematology, Director, Hematology and BMT at Max Super Specialty Hospital, Saket, Delhi. His work experience include experience of about 20 plus years and more than 1,000 bone marrow transplants. He is ex-senior consultant at Department of Hematology, Rajiv Gandhi Cancer Institute and Research Center, New Delhi. Also ex-associate professor at Department of Hematology, CMC, Vellore. His education and training include MBBS from Ravi Shankar University, Raipur, CG, India, way back in 1999. MD, Shivaji University, Kolhapur, Maharashtra in 2003. And DM from Christian Medical College and Hospital, Vellore, Tamil Nadu, 2010. He has obtained various awards to name: University Gold Medal in MD 2003, Shivaji University, Kolhapur, Maharashtra. It's my privilege to welcome Dr. Reyes Ahmed to inaugurate our webinar and give some words of wisdom. Over to Dr. Reyes Ahmed.
Thank you, Amit. And first of all, thank you to Mumbai Hematology Group, Dr. M. Agrawal sir, and all the panelists here. It's my privilege to be coming here as a chief guest. So hematology as a subject has by fascinated by everyone, required by almost all these specialities. And to name, I was working as a MD in my Solapur. Then Dr. MB had given a lecture. So much was inspiring that I said, okay, leave aside everything, I'll do hematology. So that journey and today, it's really a privilege. So after working for 3 different hospitals, finally I'm in Delhi, trying to do the same work, what we have learned over a period of time. I welcome Dr. Maria here, so she can be giving us the lecture, and we'll be eagerly waiting on the subject of MDS, a very big subject, less commonly understood. Generally, by the time it comes to us, either we are doing the transplants or we are doing just some limited drugs on the low risk MDS, high risk MDS. Most of the time we say transplant, but not more than 20-25% end up on going for transplant. So the real management, we love to see new drugs are coming in. So we are all waiting for our Dr. Maria's lecture. With this, I just open this Mumbai Hematology Group chapter. Over to you, Dr. Maria. Thank you.
Thank you, Dr. Reyes Ahmed, for that kind words and coming over here and joining us as the chief guest for the day. Now it's a time to introduce our guest speaker for the day, Dr. Maria Diaz-Campello from Spain. Dr. Maria Diaz-Campello is Associate Professor at the Department of Hematology, University Hospital of Salamanca, Spain. After graduating from medical school in 1999, she started medical training in hematology. Since 2005, she has been working at the Department of Hematology at the University Hospital of Salamanca, IPSAL in Spain. Between 2006 and 2009, she completed a 3-year postdoctoral fellowship provided by ISCII. From 2009, she was responsible for the section of morphology and hematimetry in the hematology department, and since 2017, she held a position of Associate Professor of Hematology at the University of Salamanca in Spain. Since October 2016, she is heading the myelodysplastic syndrome team at the University Hospital in Salamanca. Her clinical expertise lies in hematological malignancies with a focus on MDS and AML. The main scientific interest involves the translational exploration of innovative treatment options for these patients. She is a member of the Spanish MDS group, that is GESMD, since 2009 and head of GESMD since 2018. She is also involved in the European Myelodysplastic Syndromes Cooperative Group, that is EMSCO. It's my privilege to invite her and give a lecture on novel drugs in MDS. Well, thank you so much. Over to you, ma'am.
Good morning, good afternoon or evening to everybody. Thank you very much for inviting me to share my impression in this file with all this team. It's my pleasure to participate, of course, in your meeting this Sunday. I'm going to share my screen. I think that you are looking at this, I think, nowadays.
Perfect.
And perfect, yes. And it's my pleasure, and I like to thanks to the Mumbai Hematology Group for this kind invitation. Here you can see the title. We are going to try to review the current and the novel drugs that in the file of MDS is being working, with a lot of greetings and good news in the lower risk, and still waiting for new good news in the high risk setting, because as you previously commented, is a file very difficult to be addressed. Here you can see my disclosures for today. And I'm going to resume the goals that we are going to address during these minutes, starting with the current approach in the lower risk MDS. After that, we are going to review the higher risk setting. And to finalize, we are going to review the ongoing clinical trials that we have, at least in Europe and probably soon in your country, in the file of MDS. So let's start with the lower risk MDS. And the first thing that I'd like to highlight is that in patients with a lower risk MDS, the causes of death in these patients are always related with cytopenia. The majority of these patients are not going to be involved in an AML or high-risk transformations. Less than 30% occurs in this subset of patients, and the majority of them are going to develop cytopenias, generally anemia, and this anemia is going to be the main cause of death regarding the development of red blood cell transfusion and an improvement and deterioration in quality of life, and also organ damage due to this iron overload. So the majority of these patients in the lower risk setting, I like to highlight that are going to have symptoms and impaired quality of life and also death due to this cytopenia, mainly anemia. So the goal in this subset of patients is to improve the cytopenia in order to try to improve the outcome. And as all you know, the majority of these patients are anemic. This anemia is severe with the development of transfusion dependency in more than 50% of them, and this transfusion dependency decrease quality of life, but also overall survival. So when we are thinking to start a treatment in a patient within the lower risk setting, we not only need to increase hemoglobin level, but also we need to reach transfusion independency to avoid all these complications. Also, we have to take into account that the majority of these patients are older patients with comorbidities, so it's mandatory for the majority of these patients to have that these novel drugs have a very favorable safety profile with no adverse event that could decrease quality of life. Let's start with these three drugs in this context. The first one is the context of all drug, lenalidomide, in the context of del(5q), but in patients with no transfusion dependency. This is the concept that has been addressed in this clinical trial performed in Europe during the last years. And the goal of this clinical trial was presented in the ASET of 2022. And the goal of this clinical trial is that, as all you know, lenalidomide at doses of 10 milligrams per day is very efficient in patients with MDS and del(5q). It's a target therapy for these patients when they are in transfusion dependency, and we try to address if this drug in this context could be of interest in patients with anemia but no transfusion dependency in order to avoid transfusions. And for this reason, we designed a clinical trial with low doses of len, as you can see here, only 5 milligrams per day, as compared to placebo, only for 2 years of treatment. At the end of these 2 years, the patients withdrew the treatment and started in a follow-up period. And in this clinical trial, we confirmed that with these low doses for only 2 years of treatment, we are able to decrease and delay the development of transfusion dependency. And the median of time for transfusion dependency was not reached in patients receiving lenalidomide compared to placebo. And with this drug, in this context, we are able to avoid transfusion in the patient. Moreover, we also are able to increase the results of lenalidomide that has been seen and presented with in the context of transfusion dependency when we use this drug in higher doses. And as you can see here, erythroid responses and, more interestingly, cytogenetic responses was even higher than expected with lenalidomide at higher doses when we use the drug in the context of transfusion dependency. And of course, we have a mild toxicity, especially regarding hematological toxicity, but with not clinically relevant effects on the patient. And we also check for security regarding clonal evolution. And even in patients with TP53, we have 6 patients receiving lenalidomide with TP53 mutations, all of them monoallelic mutations. These patients also responded to the drug and did not increase the risk of AML as expected. So it's a very safe drugs in this context. So the main goal and the main idea is that we need to improve the results, and we have to avoid transfusion. Probably with this target therapy, if we have several others in this context, we need to anticipate the treatment before transfusion dependency to reach better outcomes. Let's move to luspatercept. Luspatercept, as all you know, is a novel drug in this context that is going to inhibit ineffective erythropoiesis that is present in these patients due to the presence of several inhibitors of erythropoiesis that are going to block the terminal differentiation of erythroblasts due to the presence of this link to the TGF-beta receptors in erythroblasts, and this interaction is going to increase apoptosis and stop the cell cycle, inducing anemia in patients with MDS. And the idea to target these ligands with different drugs, this is one. Luspatercept blocks these ligands that especially TGF-beta ligands regarding to activin B and several others, GDF11, GDF15. Blocking these ligands are going to avoid the interaction with the receptor, and this erythropoiesis should be restored, improving anemia in patients with this ineffective erythropoiesis. And with these novel drugs, we know that this is very efficient in patients with ring sideroblasts. As you can see here, this is the Medalist clinical trial. All you know probably know the results in which luspatercept, as compared to placebo, demonstrated superiority in the context of patients with ring sideroblasts. And this was published recently, 4 years ago, in the New England Journal of Medicine. This is the second drug in MDS published in the New England Journal of Medicine. The first one was lenalidomide in the context of DELPHA-Q, and this is the second one. And these results, this publication was based in these results. Up to 40% of the patients reached transfusion independency in patients with receiving luspatercept. And the safety profile of this novel drug is very safe and is very favorable for patients with no concerns and very similar to the placebo arm. And for that reason, as all you know, is approved. This drug is approved nowadays for patients with ring sideroblasts and transfusion dependency anemia since 2020. And nowadays, this drug has another indication for patients in first line, in patients with transfusion dependency with and without ring sideroblasts. And this is based on this novel study, the COMMAND study that has been recently published, in which there is a face-to-face clinical trial in which patients with anemia and transfusion dependency with and without ring sideroblasts was tested to receive luspatercept or EPO-alpha. And this is also a very promising drug in this context, and was published last year in the Lancet journal, translated the relevance of this novel compound. It's very relevant to analyze the primary endpoint of this clinical trial, because the primary endpoint is a composite endpoint. The patient should reach transfusion independency for at least 12 weeks, more prolonged than previously clinical trials, but also the patient needs to increase hemoglobin level, the mean hemoglobin level, for more than 1.5 grams per deciliter. And I think that this is a very good clinical point, because is traducing probably in a better quality of life for the patient. Here you can see the primary endpoint. The double of the patients receiving luspatercept reached this goal. Near 60% of them reached transfusion independence and increased hemoglobin level for more than 1 grams per deciliter, as compared to only 30% in the EPO alpha arm. This drug is favorable for the majority of these scenarios, and I like to highlight that for patients with wild type also SF3B1 mutation, as compared to EPO alpha, probably in this context, the results are close similar between EPO alpha and luspatercept. Nevertheless, as we are going to see later, the duration of the response is more prolonged with luspatercept, near more than double than as compared to EPO alpha. Here you can see the time of the duration of the response of this transfusion independency, and as you can see, is more prolonged for the majority of all the patients receiving luspatercept. And when we analyze patients with and without ring sideroblasts, you can see here also that median duration of the response, even in patients with no ring sideroblasts, is more prolonged as compared to patients receiving EPO alpha. And this superiority of these novel drugs was in favor that these drugs should be the first-line treatment for the majority of the patients. Interestingly, when they authors analyze the impact of somatic mutations in the response, they observe that patients, as all you know, patients receiving EPO alpha are more favorable to response when the lower complexity, clonal complexity in the patients. Patients not responders generally are patients with a high number of mutated genes, more clonal complexity in this setting. But regarding luspatercept, they have similar trends of response, and this is independent of the clonal complexity. No, there is no differences in these responses regarding the clonal disease. And finally, they confirmed that there were no safety concerns, no disease progression, and the results were very similar to those presented in Medalis. So with this, all this data, this drug has been recently approved by FDA, American colleagues. In Europe, is still waiting for approval, probably during this first semester, but we are still waiting for this approval. And finally, nowadays, I think that we have this option in first-line treatment. Some patients should receive ESAs, probably in the context of non-transfusion dependency, it could be the best option. Nowadays, we have to wait for novel clinical trials, as we are going to comment at the end of the presentation. Patients in transfusion dependency and with ring sideroblasts, no candidates for ESAs, probably should receive luspatercept according to the Medalist trial. And of course, with this novel trial, the COMMANDS trial, probably this option should be the first-line treatment for patients in transfusion dependency due to the more proportion of patients responding and also the more duration of the response. Finally, I'd like to comment these novel drugs, other two novel drugs in this context, imetelstat and roxadustat. These drugs has been tested in second-line treatment. Here you can see the concept of imetelstat. This is an inhibitor of this enzyme telomerase that is very high in a high expression and very active in the patients with MDS. And with this activity, patients are going to have a shortened telomere length. These novel drugs has been checked in patients with all types of lower risk MDS and in the transfusion dependency setting. Here you can see the results of the phase 3 clinical trial, emerged clinical trial, with a very similar design like a medalist trial, but including patients with and without ring sideroblasts. This is the main difference, and also very different regarding the transfusion dependency. Here, in this clinical trial, the patients in the high transfusion burden were more present. Patients were randomized to receive imetelstat at these low doses, 7.5 milligrams per kilo intravenously every 4 weeks as compared to placebo. And also the results of this clinical trial were recently published in the Lancet journal due to the impact of this result. Here you can see the main characteristics of the population. They are patients with and without ring sideroblasts. Here you can see in the slide, near 40% of the patients were negative for the presence of ring sideroblasts or SF3B1, and more than 50%, near 50% of them were in the high transfusion burden setting. And these are the main differences for the medalist clinical trial. Regarding response, again, 40% of the patients reached a durable transfusion independency as compared to the placebo arm, and the median duration of response is around 1 year, probably more prolonged than in patients with luspatercept. Here you can see the main characteristics of the patients that are going to respond to imetelstat in this dot plot. And as you can see here, patients with no ring sideroblasts and even patients with high transfusion burden are very in favor to respond to imetelstat. And it's a very good point in order to identify when we have this novel drug approved to identify the patients that are going to receive this novel drug as compared to luspatercept, because probably in patients in the high transfusion burden should be better included in this treatment regarding response, because it's probably more favorable to response to imetelstat. Regarding the safety profile, as you can see here in the slide, several patients develop cytopenias, grade 3 and 4 cytopenias, but the main idea that I like to transmit to you is that these are of short duration, generally between the 28 days of the cycle, they are recovery and with no clinical consequences. Because even that the patients develop numeric thrombocytopenia or neutropenia, we don't have bleeding events or infections that impair the quality of life or the survival of the patient. This is not like hypomethylating agents in the lower risk setting. This is the main idea of these drugs. And interestingly, for this novel drug is that this novel drug is a disease modifier drug, is supposed to be, because it's confirmed in this clinical trial and several other studies that the clonal burden decrease after treatment. Here you can see the decrease in the ball allele frequency for different mutations present in the patients, and also the decrease of this ball allele frequency is associated with outcomes, with response, with the prolonged responses or the increases hemoglobin level in patients with a lower, with a higher decrease of the ball allele frequency. So probably there is a correlation between the disease modifier activity and the response observed in the patient. And with this data, probably we have in Europe the approval soon, and FDA say yes, probably to this approval in June 2024. So nowadays, probably we have the second line treatment for patients with and without ring sideroblasts, and especially for these patients in the high transfusion burden. And here you can see the resume of the current approach for patients, hope to be approved soon. And regarding the last drug that I'm going to comment in this clinical scenario of the lower risk setting, I'd like to comment on roxadustat. Roxadustat is a novel drug also focused in the second line treatment in patients with low transfusion burden with and without ring sideroblasts. The results of the clinical trial performed internationally was presented in this the last meeting, and this result was negative. Efficacy and safety of roxadustat in the clinical trial, phase 3 trial, Matterhorn study, were presented by Dr. Mittelman in this last ASMID, but this result did not improve the anemia in this subset of patients. This is a novel drug, very interesting for the patients due to reflects the normal activity of the physiopathology of erythropoiesis in these patients. This novel drug acts in iron transportation to marrow cells, improve erythropoiesis due to an increase in EPO levels, and modulates the iron absorption in the body. So it's a very physiological drug that should be of interest in this patient, and is based on the activity in the hypoxia inducible factor inhibition. Here you can see that the inclusion criteria for this clinical trial were focused in patients with very low transfusion burden, not very high endogenous EPO level, and ESR naive or refractory. And in this clinical trial, here you can see the resume of the treatment is an oral drug. The design was compared to placebo, and the primary endpoint was, of course, transfusion independence. And here you can see the results. Due to this population is low transfusion burden, probably most of the patients or several patients were not really transfusion dependent, and is the reason why in the placebo arm there were near 30% of the patients, more than 30% of the patients reaching transfusion independence. This drug reached near 50% of the patient transfusion independence, but no differences were observed with the placebo arm due to this high percentage of responses in this arm, and the clinical trial did not meet statistical significance. Even that a trend towards to a better transfusion independence was observed with this drug, especially for patients within the higher transfusion burden that was designed like more than 2 red blood cell units per 4 weeks. This is a very safe drug with no relevant adverse events and no hematological toxicity, but finally it has not been approved for this treatment due to the result. Let's move to the higher risk MDS setting. In this setting, we have a different goal that is that in the lower risk setting, our main goal is to improve overall survival. And as you know, azacitidine is the current standard with a very limited results. The majority of the patients that lose the response after months or even any year, and there are several patients that are going to primary response to this novel drug, to this drug. Of course, we have a TP53 mutant patients that is an urgent need, because the majority of these patients are not going to respond to any treatment, and survival in this context is very dismal. And several combinations in this first line and rescue treatment has been tested, but with no very good news due to the highly toxic combinations that finally did not improve outcome. So for this subset of patients, we need to increase responses of azacitidine, but without toxicity, in order to try to improve survival. And in this context, as I previously commented, we don't have good news, because I'd like to comment several drugs that recently failed in the phase 3 clinical trials. The first one was pevonedistat. This is a novel drug that is going to inhibit this ubiquitination in selected proteins in the proteasome. And in the phase 2 clinical trial, it seems that this association of pevonedistat with azacitidine could improve responses and, of course, overall survival. The results of the phase 3 trial that has been recently published did not confirm this benefit. And as you can see here in the slide, patients receiving the combination in red did not reach more responses than patients receiving azacitidine alone. And this did not translate in an improved overall survival or event-free survival, where patients were the same receiving the combination or azacitidine alone. It's a a very difficult situation, but probably some patients could benefit for pevonedistat because, as you can see here in this slide, there is an improvement in overall survival for some patients. Here you can see those receiving more than six cycles, and in the high-risk MDS context, suggesting that probably this drug can probably benefit different subset of patients, but these are not identified in this clinical trial, and this drug was discontinued for the study in high-risk MDS. Another similar result we have observed with APR-246, eprenetapop, that is a novel drug that also failed in the phase 3 trial. And in this, with this compound, the idea is to reactivate the mutant and inactive p53 protein. This novel drug reformulates the molecular structure of this compound p53 and restore the activity of this gene and this protein. The results of this clinical trial, this is the phase 2 clinical trial, seems promising, especially for patients in the MDS setting, as compared to those with AML or more AML with more than 30% of blast, with a very high number of responses regarding also complete responses and with an interesting duration of response. Patient responding seems to have this response due to a decrease in the allele frequency of TP53, traducing the idea that this is a target therapy and probably interesting for the patients. And as you can see here, the decrease of the allele frequency was observed in patients in response and not observed in patients not responding to the drug. There is a trend to improve overall survival in a few patients responding to the drug, but and also no safety concerns due to hematological toxicity or other, especially neurological toxicity. And we only have to take care with patients that are older or with renal impairment, because in the other patients there is no problem. There are no problem with the hematology, with the toxicity. Nevertheless, when we started the phase 3 trial, as you can see here on the top of the slide, the phase 3 trial failed to reach the primary endpoint, that was complete remission, and it was achieved only in 30% of the patients in the combination arm of azacitidine plus eprenetapor, as compared to azacitidine alone, in which there is only 22. So this novel compound is still waiting for further clinical trials to perform the benefit in this patient. We have also two failures regarding immunotherapy in this context and during this last month. This is the first one, anti-CD47 magrolimab. This novel compound is a very interesting drug targeting the immune system in this disease. And the idea with this novel compound, magrolimab, is an antibody targeting CD47 that is going to stimulate the macrophage to target a cancer cell, because this cancer cell has a CD47 signal that is a don't eat me signal, and with this antibody, magrolimab, we are going to block this signal, inducing again the phagocytation for macrophage for the CD cancer cells. The results of the phase 1 study were very promising, especially in patients with naive for treatment, with a very high percentage of patients responding, and with especially very promising results, it seems, in TP53 mutating patients, where the results were close similar to patients wild type. So it seems to be a very promising novel drugs. Here you can see a resume of the the results for one patient in which the ball allele frequency decreased after treatment and also the bone marrow blast, and it's very promising, especially for this subset of patients. Nevertheless, the phase 3 trial that is going to be probably presented in the next EHA meeting did not translate in benefit for the combination as compared to azacitidine alone. And here you can see the press release of the company in which they confirmed that the ENHANCE study, that is the phase 3 trial, randomized in more than 500 patients, did not have the impact in overall survival and response rates, and the company discarded this novel drug for the development of high-risk MDS. And also the same situation has occurred with these novel drugs, anti-TIM3 antibody, sabatolimab. This is the novel drug that is targeting this ligand, TIM3, that is present generally only in leukemic cells. It's not present in normal, healthy CD34 cells, and this antibody, this ligand, is blocking the actuation of the immune system due to this leukemic stem cell, and is only this ligand is only being linked in with the galectin-9 and promote the leukemic stem cell self-renewal. With this novel compound, sabatolimab this novel drug is going to be this TIM3 in these leukemic cells, also in these immunomodulators cells, T and NK cells, and also macrophage. And the goal of this novel drugs is to inhibit this cell renewal leukemic stem cell, and also target that this cell should be destroyed by the immune system. The combination of this novel drug is also, again, with hypomethylating agents, azacitidine and decitabine, and with different dose levels of this compound. The results of this phase 1 trial seems to be also promising, with an increased response rate, with a prolonged duration of the response, and probably with a very good response even in patients with adverse risk features like TP53, cytogenetic poor risk. You have seen here in the slide that there were promising response rate in this subset of patients. But again, when we performed the phase 3 trial, including more than 500 patients, high-risk MDS patients, as compared to azacitidine alone, the primary endpoint was not met, and the company that is, in this case, Novartis, discard again this novel compound to the development of this in this context. And probably these results should be also presented in the next European meeting. Nowadays, we have only this novel drug waiting for the results. The phase 3 is ongoing. We are still waiting for the final results of this phase 3 trial, and we hope this novel compound should be positive for the patient, but we don't know due to the latest news with these other compounds. Here you can see that this novel compound tested in lower risk MDS is very toxic. So the dose selected for patients within the high risk MDS patients is of only 400 milligrams during the first 14 days of the 28 cycle with azacitidine. The combination of these two drugs, azacitidine and venetoclax, is very toxic for a patient. Here you can see the results of the phase 1 trial, and here you can see that several patients develop a very severe myelosuppression. So we have to take care, especially if these results are positive, with this situation at the beginning of the 6 cycles in this combination. Nevertheless, the patients reach a very profound response, and as you can see here, the majority of the patients, near 85%, reach response with a median time to response very quick, less than 1 month, and the median duration of the response very prolonged, more than 12 months. Also, patients with adverse features like TP53 or even other adverse mutations reach response and also reach molecular response. These are the results of the phase 1 trial presented in as a meeting, and it seems very promising for the patients because patients reaching this profound response had an improved outcome, as you can see here in the slide. And when we analyze different type of mutations that you have here in the slide, and you can observe how the majority of these mutations decrease or even disappear after treatment. So producing a very profound response in these patients. Nowadays, we have to wait for the results of the phase 3 because it's ongoing and it's waiting for the events. Probably at the end of this year, we have the final results, and in these results, we are going to see if this combination of azacitidine plus venetoclax improve overall survival. That is the main goal of this clinical trial. Let's move finally for these ongoing clinical trials. We are going to see these novel compounds in the lower risk MDS and in the higher risk MDS setting. And with these figures that translate that the clinical trial is ongoing, is stopped due to different evaluation, or is still not started. Here you can see the novel compounds in the lower risk MDS treatment. I like to start with luspatercept because this is nowadays an old drug, but in this clinical trial, the upcoming clinical trials, we have now 2 ongoing in Europe. That is our phase 3 trial, trying to start the luspatercept at the maximum approved dose. As all you know, we have to start at the dose of 1 milligrams per kilo, and we have to increase the dose for patients not responding. The idea of these 2 clinical trials that we are performing in Europe is to start directly with the with the highest dose, 1.75 kilo per kilo every 3 weeks, and if the patient responds, decrease the dose. These are the 2 clinical trials ongoing. This is one for the EMSCO platform, and this is one for the BMS company, and is for patients with the same criteria of the medalist clinical trial. And the idea is to avoid or delay the increase dose for patients that are going to not to respond, and to start with this high dose as we usually do in patients with ESA. And the other clinical trial that is currently ongoing in internationally is the clinical trial in which luspatercept is compared face-to-face with EPO-alpha in patients with anemia, but no transfusion dependency. As you can see, is the main idea that we have in the Sintra-Rev clinical trial, trying to avoid transfusions in this subset of patients. The inclusion criteria is for patients with no transfusion dependency anemia and with and without ring sideroblasts. So it's a very promising clinical trial, trying to avoid the development of transfusion and trying to improve quality of life in anemic patients with lower risk MDS. And this could modify the current approach that we have, that generally these patients receive EPO-alpha. Nowadays, we don't know if it is better luspatercept. Also, we have a very novel compound in our center and also internationally, that is a novel modified activin receptor type 2I ligand. This is a novel compound that are going to target not only activin B and different GDF for the for the ineffective erythropoiesis. This novel compound that is called KER050, KER015, elritercept, is going to be also activin A. And with this inhibition, it's only to improve not only erythropoiesis, as it happened in luspatercept. This novel compound should improve also thrombopoiesis, bone marrow formation, and improve the utilization of iron, and also probably could be a disease modifying due to the inhibition of this inflammation. We have this clinical trial ongoing. It's a phase 2 trial, including different patients with different characteristics, ring sideroblast, non-ring sideroblast, and transfusion-dependent anemia or not. And the drug has been recently presented in the last SAS meeting, and is going to also be presented in the next EHA meeting, the results of this phase 2 trial. And the general idea is that safety is very good for the patients. We don't have any safety concern. The most frequent adverse events were related to fatigue, nausea, headache, or diarrhea. The majority of them were grades 1 and 2, and there is no treatment-related discontinuation or death, and no patients progress to AML. And regarding response, it's very promising drug because improve hematopoiesis, especially for patients within the lower EPO levels. And as you can see here, there is no differences between the all cohort and the high transfusion burden cohort. There are similar results regarding response between these two subgroups, reducing the impact of these novel drugs. And also, this novel drugs is of interest for patients with non-ring sideroblasts. Probably we have to wait for the final results and probably the update in the EHA meeting. Also, with this novel compound, we also see improvement in other lineages. And as you can see here, the majority of the patients with low counts of platelets increase the platelets counts after treatment. And also we have communicated in the last SAS meeting that there is an improvement in other aspects of the patients regarding iron overload, bone formation, and myocardial stress. And the phase 3 clinical trial with this novel compound is ongoing. It's focused in patients not receiving luspatercept, luspa-naive, and within the transfusion dependency setting. There is the clinical trial comparing CARE-015. The administration is also subcutaneously every 4 weeks as compared to placebo with a crossover approximation. Another novel drugs in this context is this compound, mitapivat. This is a small molecule, AG946, that is an activator of different pyruvate kinase isoforms. Even that we don't have mutant pyruvate kinase isoform in this in MDS, as all you know, there is an inadequate production of ATP due to a lower activity of PK activity. And with this novel compound, we are going to restore this activation in order to increase the viability of the erythroblast. The design of this novel compound is a phase 2 clinical trial with different drugs, 5, 3.5, 2, 3. We have different cohorts of different dose levels. And regarding the safety, there is a very good drug with no relevant adverse events. And the clinical data that was presented with these first patients included identify that some patients reach transfusion independency and some patients reach hemoglobin improve. So the clinical trial is ongoing with this novel compound due to these preliminary results. And finally, regarding the lower risk MDS, I have this novel compound ongoing in my center that is a first-in-class small molecule, is an inhibitor of this cyclin-dependent kinase, CDK8 and CDK19. that is a combination that promotes tumor growth, and in this novel compound binds this kinases, cyclin-independent kinases, blocking this fusion and inducing apoptosis of the malignant clone in this subset of patients. We have this clinical trial ongoing, this phase 2 clinical trial with this novel compound that is orally administered, and the results still that we have are based on only the phase 1 study in relapse refractory AML and high-risk MDS, in which several patients develop hematological improvement with erythroid response, and this is the base that this novel compound move to the lower risk setting. This novel compound is being tested in high-risk MDS, but due to the fact that several patients improve the thrombopoiesis and erythropoiesis, this novel compound has also tested in patients with lower risk. And the last dose in drug in this lower risk setting is pelabresib. This is, as all you know, a BET protein inhibition with this compound is observed in patients with myeloproliferative neoplasms. And due to the fact that this novel compound promote erythroid differentiation and megakaryocyte differentiation, is going to be tested also in patients with lower risk MDS, starting with this oral drug with these two schemes of different dose levels in order to address anemia in these patients. And finally, we are going to finish with this higher risk MDS treatment, these novel compounds. This is the most advanced drug, this tamibarotene. It's the SELECT trial that has probably recently finished the recruitment with near also 500 patients included, and this novel drug is going to target RAR alpha. As all you know, in several myeloid diseases, there is an overexpression of RAR alpha that is going to lead several RAR alpha unligaded, and this situation is going to inhibit the myeloid and the normal myeloid maturation in these patients. And with this novel compound, that is tamibarotene, is similar to the retinoic acid, and is going to bind this overexpressed RAR alpha ligands in the bone marrow of these cells and induce the expression of the different target genes to restore this myeloid signaling. This is a similar compound like ATRA, as like a super ATRA, and is an activator of this RAR alpha. And the phase 3 trial has included more than 500 patients, as you can see here, and this novel compound is combined with azacitidine orally during the days 8 to 28. We are now waiting for the results, but it seems that it not increase hematological toxicity or other toxicity. As you can see here in the slide, it's very similar to the safety profile of azacitidine alone, and probably there are some data of some activity in patients with high-risk MDS and AML, because this drug could target blast cells. And the last compound is a novel BCL2 inhibitor, is sonrotoclax, and is a novel inhibitor of this pathway that is going to probably be more intense regarding apoptosis of the blast cells in this high-risk disease. The design that is currently ongoing is a phase 1b and 2, open label, dose finding and expansion in patients that has relapse or refractory to azacitidine. And we are participating in my center in this dose escalation that includes different cohorts of azacitidine and also of sonrotoclax. The main problem of this compound probably also is like venetoclax, is safety, because the most frequent adverse events are related to hematological toxicity, and we expected to have several responses, as you can see here. Even in patients with relapse or refractory situation, there is a very interesting rate of responses in these patients. We are in this phase 1b trial looking for those and toxicities. And finally, I'd like to comment that there are several other novel drugs nowadays targeting IDH in combination or IDH1 or IDH2 targeting in combination with azacitidine. And there is a novel compound now looking for the CD123 targeting, that is a ligand generally expressed in the myeloid cells. And finally, we are also participating in the development of CAR-T, in this context, CD33 CAR-T, with allo CAR-T cells in order to be tested in patients candidates for allo transplant. And that's all. Thank you very much. This is my team in Salamanca and in the clinical trials unit. And I'd like to say thank you very much for your kind invitation. Thank you.
Thank you, ma'am, for that wonderful insight into all overview of MDS, from old journey to new journey of MDS. Thank you, ma'am, for that fantastic talk. And now I request all our discussants to please put the raising sign so that we can start our question answer session. Agarwal sir, your question, please.
Thank you. First of all, great talk. Enjoyed it a lot. I have a couple of questions related to Luspa. First,
yes.
Whether there is any dose-related toxicity of Luspa?
No, I think that there is no dose-related toxicity in the clinical trial. The maximum tolerated, the maximum expected dose is 1.75, but because it was the dose related to the higher response, but there is no DLA related to this. No, the increased dose did not translate in an improved response, and this is the reason why it's not explored, but now based on toxicity. We have only taken care probably with hypertension with this compound, because some patients could develop hypertension, but generally it's based on the patients and the situation before receive luspatercept. And there is no other relevant toxicity with this compound.
The second question is again related to Luspa. After how many weeks or months do you say that the drug has failed?
Regarding response, yes, it's important. I think that if the patient is not responding to the drug, you need to increase the dose up to 1.75, because some patients need the higher dose to respond, especially those within the high transfusion burden, that they are the most candidates to receive the higher dose. So I think that if your patient is not responding, you should increase the dose up to 1.75, and at least the patient should receive 3 cycles of this dose level to identify the patient is not responding, because otherwise some patients should be discarded and could probably benefit for this drug. So you need to, at least if the patient is not responding, increase the dose up to 1.75 and administer at least three cycles. That means 18 weeks for identification if the patient is responding or not.
Okay. Is there any trial ongoing in the combination of Luspa with EPO?
It's very interesting. I think there is several ones in the United States and not in Europe. And the French group is starting a phase 1 and 2 clinical trial also in the combination with these two compounds. And I think this could be of interest because of the two drugs seems to act very synergistically, and is of course of interest. And I think that luspatercept is also a very good drug to be tested in combination with other compounds, probably lenalidomide in the context of non-del5Q, also imetelstat, because the safety profile is very good with no hematological toxicity and should be of interest to be checked with another combination, as azacitidine or other. I think that there is a very good drug to be tested in clinical trials in order to address anemia.
And the last question is, are there response predictors?
It's a very difficult question. There are no very good identifications or response. Regarding luspatercept, the majority of the patients that are going to respond are those in the low transfusion burden, and of course those with the high platelet counts. But I think that this translates that the patient that is going to respond even better is this patient with the low burden of the disease. At the beginning of the disease is more clear to be responded. So we have to move to an early treatment of these patients as soon as the patient becomes transfusion dependent, because probably the probability of response is more higher than if you delay the treatment after several months or years.
Are there patients who have sustained response and you're able to decrease the dose or stop the drug?
Yes. There are several patients in which we have a very good response in the clinical trial that I comment, in which we started with the highest dose level. We need to decrease due to very profound, incredible responses. And some patients reach more than 12 grams per deciliter of hemoglobin, and we have to stop the drug and decrease the dose after hemoglobin drops, and to keep the patient on treatment. And there are some patients in which we can increase the weeks for administration. Even every 3 weeks, we can delay up to 4 or even 5 weeks due to the hemoglobin levels in which the patient is still stable, and you don't need to administer the other dose of the drug.
One last question. If you stop and then the hemoglobin drops, when you restart, the response is equal?
Yes. It's very similar to ESA, and if you restart the patient the drug again, you should reach again the response. You should restart when the hemoglobin level is between 10 and 11 in order to avoid transfusion dependency again, and the responses are quite similar to the beginning. So
thank you so much.
Thank you.
Thank you, sir. Dr. Aditya Jandal, your question.
Thank you for the fantastic talk, ma'am. My question is like from the conceptual standpoint. You mentioned about more than one drug, including magrolimab, which actually generated a lot of optimism and excitement with the initial phase 1, phase 2 results. But when they were tested in the phase 3 setting, so the trials were either stopped or they were found to be inefficient. So what is the reason that a particular drug is showing good, decent amount of single agent activity, but when it is combined with azacitidine, it is not showing benefit? It is something that is contrary what we see in other hematological malignancies like multiple myeloma, where we say that there should be some amount of single agent activity that a drug should provide, so that we can see enhanced synergism with the other drugs. So in your opinion, what is the reason? Is it the biases involved in the initial phase 1, phase 2 study, the selection as far as selection of patients is concerned, or there are some other reasons?
I think that probably in this situation, in the high risk setting, I think that the heterogeneity of the patients included in the clinical trial is the reason of fail, because I'm clear have faith that these compounds are of interest for several patients. I have several patients in the pevonedistat trial in which responses were very prolonged and more than 3 or 4 years. So I think that they are respondents in each clinical trials, but in the main population, they are diminishing and are not arising. So probably we are mixing several populations in these cohorts. The majority of the patients are not going to be benefit for this clinical for this combination, but I think that we should focus on patients in which this combination should be optimal. And but the companies, when they don't have a positive results, because probably they have spent a lot of money in the design and in the clinical trial, they don't want to analyze patient population and focus in another clinical trial, only focus in these responders. But probably there is a subpopulation of specific patients in which this drug should be of interest and increase responses, but we don't know why in the general population probably there is only an amount of patients in which the drug is of interest. And because regarding the different places and countries included in a phase 3 trial, that it should be another point of discussion. I think that the majority of the centers nowadays treat very good patients in the hybrid setting, and it's not the differences between one and others is not including patients, like as comparing with the phase 1 and 2 trials. There are no relevant differences, even that it should be another idea of failing.
So, in your opinion, these drugs, will they ever see, approval in near future? Especially, I'm talking about magrolimab, because that generated a lot of, excitement. Because TP53 mutated disease, we all know that it is a hard task. So, what is your opinion?
Yes, I think this is the main goal, and probably we need another tools to identify the benefit of any drug in this context. Sometimes artificial intelligence or other tools probably should be incorporated in clinical trials to better identify these novel compounds in which this drug should be benefit. In the last European School of Hematology meeting, we assist to a presentation of Dr. Amit from the USA, in which he analyzed the results of the phase 3 trial in combination of azacitidine with lenalidomide and other compounds, and analyzing this clinical trial with artificial intelligence. They identify different subpopulations in which the drug sometimes is benefit for a subgroup of patients, but with the tools that we are currently using, that is IPSSR or even molecular IPSSR, we are not able to identify this subset of patients. And especially for TP53 patients, I think that the goal is completely different for others, in which because overall survival is even shorter, so probably an improvement in 3 months or even 4 months should be enough for this subset of patients, or even to reach complete remission to try to move the patient to the transplant. I think this is a very good goal for this subset of patients.
Thank you.
Thank you, Dr. Aditya. Dr. Agarwal, sir, your question?
Yeah, I have a couple of more questions. One is about how often you use TPO-RA, eltrombopag and romiplastim in these patients?
Yes. I think this is a very good question, a very interesting question. We use this drug, especially in patients within the lower risk setting that presented with thrombocytopenia and with no increased blast in the bone marrow. With less than 5% of blast, I think this drug is safe. And we have several patients responding to these novel compounds of thrombocytopenia. The clinical trials did not reach the approval for this drug romiplostin or even eltrombopag, but we think that based on the results of the phase 2 and phase 3 trial performed in Europe generally, we have these responses in the platelet counts, and it's a very safe drug in these patients. And we use it in there are no a lot of patients with this characteristic, but if you have a patient with a thrombocytopenia in the lower risk setting, is of course a very safe and efficient drug in this context. We have several respondents.
What would be your starting dose of eltrombopag for MDS?
I think that we should start in 50 milligrams per day, and we increase up to 75 regarding the response of the patient. We start with this dose level, 50, and if the patient did not respond, we increase those up to 75. Yeah.
The other question is about immunomodulatory drugs. So any subset of patients of MDS, you still use drugs like anti-thymocyte globulin, cyclosporine?
In my experience and in my center, I've never used this drug. Even that we are working on it more than 20 years, we don't have any patient candidates for this treatment. I think that if the patient in the lower risk setting has disease characteristics to be candidate for this treatment, the majority of these patients are going to be transplanted. So because this the treatment is very toxic for the patients, reach responses only for a few months or even 1 year. And after that, the patient should again relapse, and probably the majority of the patients candidates for this are candidates for allotransplants. And in my center, we move to allotransplant. And in patients not candidates to allotransplant, they are too older to try to use this drug. So we don't use this drug. It's always in the text and in the books and in the papers, but I've never seen any patient candidate in at least in my center and in my experience. I'm not sure if you use this therapy.
If there is hypoplastic MDS with cellularity just less than 10%, etc., then we are using it in India.
Mm-hmm.
Okay. The other question is related to, we used to do karyotyping. Then we started doing FISH, and now we have NGS. Should we do all these three for all the patients, or with NGS you can bypass FISH or even the karyotyping?
Yes. We all in all patients we perform karyotype, of course, and if possible we perform NGS. And FISH analysis, I think that is at least in Europe is not cheap, and we think that it's better to perform NGS and not FISH analysis, because the information that NGS shows is more relevant for the patients in order to address prognostication and probably target therapy if possible. So in the majority of them, we perform only karyotype and NGS. And we are nowadays trying to incorporate optical genome mapping in order to identify in which patients is of interest, probably in those with no metaphases to be analyzed. We are performing this approach of optical genome mapping in the patients with MDS, but I think this nowadays is under investigation and is not recommended for clinical practice.
Right. And the sensitivity of NGS from peripheral blood is as good as that from the bone marrow?
Yes. I think this is completely the same. The recommendation is to perform this in bone marrow or in peripheral blood at diagnosis, because the majority of the clones present in bone marrow are present in peripheral blood. The only recommendation to perform this technique in bone marrow, if you like to address minimal residual disease, you should go to the bone marrow. But for diagnosis and prognostication, I think is completely the same. So you can move to peripheral blood.
And the other question is about when you are planning to transplant a patient of higher risk MDS. Are there guidelines that what you should achieve with HMA before you transplant? Are there clear-cut guidelines?
No, I think there are no clear guidelines. In our experience in Spain, we used to start treatment when the patient is around 10% of blast or more. We decide to start with treatment before transplant. And nowadays, we generally use the combination of azacitidine plus venetoclax in this subset of patients because we reach responses very quick with the combination. In 1 or 2 months, you have the patients in complete remission, and these responses are of more deep responses, sometimes molecular responses. And we think that it's better if you plan to perform the transplant to move to this type of response before transplant. So we generally, when the patient is candidate to allotransplant in the high-risk MDS setting, we start the transplant procedures as soon as possible, and we start with ASA plus venetoclax, and we move to the transplant after 4 cycles, as soon as the patient reaches a response. And in the majority of the patients in my center are moving for intensive chemo to ASA plus venetoclax in order to avoid hospitalization and complication of chemotherapy. I'm not sure what is going to be the results of the Verona trial, the phase 3 trial of the combination of azacitidine and venetoclax, because it's a different population. But in younger patients, I think this should be the approach for candidates to allotransplant.
And in your experience, you're able to give 400 venetoclax for 14 days to almost all patients?
Yes. In younger patients, only in younger. In elderly, I think this too toxic. Probably the results of the Verona, I'm not sure, but it's difficult to be positive. But probably the dose is still too high for older patients. For more than 20 patients is too toxic. And in Spain, we have patients of, I know that in India is different, but we have patients of 85 years old in which you cannot start this with this dose level because you probably kill the patient with this first cycle due to an infection. So I think that the dose, especially in elderly patients, should not be 14 days, probably 7 or even lower doses of 200, we don't know.
So I'm coming back to my original question. When you said the moment patient responds, you will transplant, you also use the word 4 cycle and then transplant. So exactly how do you define the response? Morphological, MRD, molecular? How do you define that?
We try to do it by morphology. And if possible, we also check for flow cytometry if the patient has a excess of blast to identify the blast count. And nowadays we are incorporating molecular markers, but the majority of the patients, when we move to the transplant, we don't have the results of the molecular analysis. So we are blind to this response. So probably we look only for morphological and flow cytometry. And also if the patient has a cytogenetic abnormality, we also check for cytogenetic response, of course, but generally it's morphological test. Yeah.
If you're left with say 2-3% blasts on flow, or your cytogenetics is still positive, you finished 4 cycle, you will go ahead with the transplant, right?
Yes, of course, because this is the only way to try to improve outcomes. Even if the patient did not have a very good response, probably with the transplant, it happened. We also have recently reviewed the experience of transplants in patients with TP53 mutations, and even in patients with biallelic mutations, so multi-hit, transplant improve outcome. Even that the patients finally is going to die due to the disease, but the overall survival is improved with the development of allotransplant, and probably you are allowing the patients to improve outcome due to this approach. So even in patients with multi-allelic PTP53 situation, we recommended allotransplant.
Will you transplant these patients even after 1 or 2 cycles of AZA plus ven, or you will give minimum of 4?
Yes, we try to perform at least 3 or 4 in order to decrease the residual disease, but and sometimes when even since you diagnose the patients and just look for a search for a donor and apheresis, it takes probably 3 or 4 months. So we have enough time to perform this treatment.
Your comments on oral azacitidine for low risk MDS?
It's complicated because the clinical trial was negative due to the toxic dose selected. I think that this is a very interesting compound, but the dose level should be decreased in order to not to reach this toxicity. But the company did not address any other clinical trial in this setting, and is nowadays is not approved. And at least I think internationally, BMS has stopped all the clinical trials with this oral compound. So due to probably the level, so probably we should move to a investigator clinical trial to try to address the optimal dose. I think it's of interest in a lower dose and probably at the end of the other drugs, because after azacitidine, as all you know, in MDS, there is no way for anything. My impression is that when you treat a patient with azacitidine, there is no other option after that. So I move this compound for the last drug in a lower risk patient, but it's of course of interest if the patient has high transfusion requirements.
Thank you so much. Thank you.
Thank you, sir. There's a couple of questions, man, from the audience. Dr. Krishnanathan Karan wants to know again the same thing. When do you consider allotransplant in low risk MDS, and when you will consider in high risk MDS?
Oh, this is a very good question, because in MDS, the majority of us think that we should move to the transplant, of course, when the patient starts to have high-risk features, an increased blast or a cytogenetic evolution. Of course, this is very easy to identify. If the patient has 3% of blast and move to 6 to 7% of blast, probably the disease is evolving to a high-risk feature, and you can proceed to allotransplant. Of course, in cytogenetic, again, in patients with a deterioration of other cytopenias, so the appearance of other cytopenias, for example, neutropenia or even thrombocytopenia. And the most difficult thing, I think, is in the patient with only transfusion requirements failing to different treatments, because sometimes we have a stable disease in the lower risk setting with no increased blast, no adverse cytogenetics, no clonal evolution, and you have a transfusion burden that is increasing and failing to different options. And I think this is the most difficult patient you need to move to transplant. And in my center, we used to identify the time to transplant in this subset of patients based on the myocardial toxicity, because sometimes this patient start due to the iron overload to present it with cardiac toxicity and cardiac function, sometimes with the cardiologist evaluation, sometimes should make us to move to transplant even in the patient if the patient had no adverse features. And my last patient recommended for allotransplant was a male of 55 years old, in which several treatment has failed. The last one, I think, that was luspatercept, but he also received imetelstat and several others, and the patient has a very high transfusion burden. And we decided to move to transplant due to the cardiac function, in which there were relevant cardiac iron overload, and we decided to move to transplant in this situation, even that the disease has a very low prognostic index by IPSS-R or even a molecular IPSS-R. But if we don't go to transplant, the patient should need more transfusion, and probably we cannot go after that due to cardiac toxicity. Regarding high-risk patients, I think if the patient is candidate, we move to allotransplant as soon as possible, and we try to keep the patient in transplant as soon as possible. Due to we used to pre-treat the patient as a bridge to transplant with chemotherapy several years ago, and nowadays with azacitidine plus venetoclax nowadays in order to decrease the disease burden and to prepare the patient for transplant. But we identify in the high-risk feature as soon as possible the donor to move to transplant. And we don't wait or delay the transplant even if the patient is responding.
Thank you, ma'am. And ma'am, on the same note, how frequently are you checking for liver iron overload in case of low-risk MDS? And if LIC is very high, do you go for transplant?
Sorry, I can understand you.
How frequently are you checking for liver iron overload?
Yes. Liver and iron overload is very frequent in this subset of patients, and we perform MRI in our patients every year. The majority of them have liver iron overload, but we think that this is not a cause of death in any patient. So probably it's not a situation in which we decide anything with the patient based on this liver overload. Regarding the cardiac, is completely different because the main causes of death is a cardiac event, and we move to different approaches based on this toxicity. In general, we used to chelate all patients with lower risk MDS receiving transfusion, but sometimes even with chelators, the iron overload is increasing, and the liver is the first organ that in which you can identify this situation. Yeah.
Thank you, ma'am. Sir, you had a question?
Well, related to the same thing, whether you, based on ferritin, you start and stop the chelation?
Yes. We start ferritin chelation if the patient becomes transfusion dependent as soon as the patient receives at least 20 units or even increase ferritin levels for 1,000. And we used to stop when the patient is around 500. Yes, between 500 and 1,000, we used to stop. It's not frequent because even with chelators, if the patient is in a high transfusion burden, it's very difficult to keep ferritin lower, and sometimes we need to use 2 chelators. But especially in patients reaching prolonged response to different drugs, luspatercept or even imetelstat, you can decrease dose level or even discontinue it for chelators if the patient reach these levels. And it's important to discontinue because if not, this drug is going to chelate another metal in the body and should damage the patient. Yeah.
Thank you, sir. Another question, ma'am, from Dr. Gaurav Lalwani. If a patient is low-risk MDS, SF3B1 mutation positive with ring sideroblast, but refractory to erythropoietin, refractory to lenalidomide, refractory to luspatercept, what would be your next line of therapy now?
It's a very difficult question. Probably if we have imetelstat available, this should be a very good option for the patient because patients with these characteristics are going to respond even better to imetelstat, but this drug is still waiting for approval. Also, CARE 050, elritercept, is a drug that is of interest even in patients with these characteristics, but also is not approved. And outside clinical trials or this, you can choose low dose of azacitidine if the patient is in a high transfusion burden. I think that low doses of azacitidine for 5 days only could reach transfusion independency, but you have to take care with toxicity. This is my opinion regarding the available drugs, because otherwise, if there is a clinical trial, it should be the best option, but sometimes you don't have a clinical trial or access to novel compounds, and you have to try to use traditional available drugs like azacitidine.
Thank you, ma'am. Another question from Dr. Gaurav Lalwani. What are the options available for MDS increased blast 1, IB1? With trisomy 8, patient was started on azacitidine, progressed to IB2. Then they added venetoclax, but patient did not show any hematological response, and patient is not affordable for allogeneic stem cell transplant.
Well, I think this is a very common situation because sometimes patients fail to azacitidine, and even you can add different drugs like venetoclax. This is the approach in my center we should done. But after that, we don't have any other option available. We move the patient to palliative care probably because we don't have any available option. Nowadays in my center, you can use a novel inhibitor of BCL2, but it's on rotoclass in a clinical trial. But outside clinical trials, I think there is no a very good option for the patients. And we normally moves to palliative care in this subset of patients because survival is very small and you have only 2 or 3 months of expected overall survival. So probably it's not reasonable to move to intensive chemo or other approach that should be very toxic for the patients and are going to decrease quality of life with no responses and no improved outcome. So we move to palliative care. Yeah.
Thank you, ma'am. Another question from Dr. Gaurav Lalwani. Do we need to screen for any autoimmune disease in low-risk MDS with anemia, and any role of adding steroids in low-risk MDS with anemia?
Yeah, it's a very interesting question because the majority of the patients develop autoimmune disease. We don't use it. We don't generally test for these autoimmune diseases. We generally ask in the clinical interview for other diseases, but we don't have this screening in this subset of patients. Even that is very frequent. And regarding treatment, I think that sometimes when you treat the patient within the lower risk setting, you need also to treat the concomitant autoimmune disease with the different treatments. Sometimes the development of the evolution of the diseases are not similar, and autoimmune disease is by one way, and the MDS and transfusion dependency by other. In the high risk setting, sometimes when you treat with azacitidine, you can improve the symptoms of the autoimmune diseases. There are several papers regarding this issue, but it depends generally of the patients and the disease. It's very difficult. Yeah.
Thank you, ma'am. Another similar question from Dr. Hitabi. Can you combine TPO receptor agonist with azacitidine, HMAs?
HMAs with
TPO receptor agonist, L-Thrombopac?
I think this in the high risk setting is not recommending based on the results of the clinical trials in which they confirm futility with a combination of L-Thrombopac plus azacitidine. patients in this combination responded lower and had not an improved outcome. So in my opinion, it's not recommended to a very good option to combine. The patient in a very thrombocytopenic situation, in my center, we used to start azacitidine intravenously in order to avoid toxicity for the subcutaneous administration. And if the patient is going to respond to the drug, platelet counts are going to increase very soon after 1 or 2 cycles. So it's not needed to address to associate el thrombopag. If the patient is not responding, probably you should discard azacitidine. But the combination nowadays is not recommended based on the results of the clinical trial.
And any experience of any patient developing thrombosis or any thrombotic event when on L-thrombopag in low-risk MDS patients?
No, in my experience, no. You can reach increased platelet counts, but again, you have to check every month or every 2 months for the numbers. And if the patient reaches a very good response, you can discard also or decrease the dose of the thrombopag in this subset of patients. But we don't see any thromboembolic events, no, thrombotic events, no.
Thank you, ma'am. Another question from Dr. Hita B. If the patient is high risk, not proceeding to allotransplant and started on HMAs, should HMA be given till the disease progression or can we stop after achieving the best response?
The problem is that if you stop the drug, the patient should be relapse in a few months. So the best option is to start and keep on treatment until disease progression. It sometimes happens several years. It's important that the patient did not present toxicity, because sometimes when the patient responds, sometimes the patient can develop hematological toxicity, and sometimes you should move the treatment instead of every 4 weeks. You can move for every 5 weeks. I have several patients in this situation, especially prolonged responses, but it's better to keep on treatment with lower doses than to discard of treatment, because all patients that discontinue azacitidine are going to relapse. So it's better to keep on treatment.
Thank you. And this is true for even CMML too?
Well, yes, it's the same, but CMML2 is always poor, of poorest results regarding response and survival. It's still even poor than high-risk MDS. So it's the same recommendation, but with shorter or poorer results, because CMML nowadays is a hardest disease, probably even worse than TP53 mutant patient, because the results in this situation, in this disease, are very bad.
And the question from Dr. Amit Kumar: any treatment change for MDS with fibrosis?
Yes, it's difficult because this complicates the treatment, increases cytopenias, but there is no other modification of the regimen of the recommendation. The fibrosis always increase the risk of the patient, so probably the patient is in the lower risk setting with intensive fibrosis. It should identify a high-risk MDS patient, but the approximation for this patient is the same that in other patients with high-risk disease. It's a very difficult feature to be targeted. And even after allotransplant, some patients after transplant still presented with fibrosis that sometimes is reversible after several months of transplant. But it's a very difficult feature to treat.
Thank you, ma'am. So as of now in 2024, every high-risk MDS patient who are going to be transplanted, ESA plus when is the role, or any subgroup of patient you will offer 3+7 also?
No, I think that if you are you have an allotransplant candidate, you should always transplant the patient, because as a ven, the combination should be limited in the time, and the majority of the patients are going to relapse after a few months. So if you have the opportunity to transplant the patient, it's better to keep this approach for the patients in order to increase outcome, because otherwise the patient should relapse, and after the relapse is more difficult to be transplanted, because you have to change your treatment, trying to reach again a new response, and after that to move to transplant, and it's more difficult after this failure. So I think that if the patient is candidate to allotransplant, as soon as possible, it's better to move to transplant.
Thank you, ma'am. Another question from Dr. Mona Vijayan. Any experience of weekly low-dose decitabine and venetoclax in MDS IB2, especially in TP53 mutated patients?
No, in Europe it's not approved. There is no approval for the decitabine, and we cannot use this drug in MDS. But I think that is of course of very interest, especially nowadays that we have the oral combination of decitabine and cedazuridine in patients with AML. So probably in the near future we can move to this approximation of oral therapy in combination of decitabine and venetoclax. I think this could be a very good option, and probably we should use decreased dose of hypomethylating agents or even venetoclax, but it should be very, very promising for the patient, but we don't have in Europe the opportunity to use decitabine in MDS. Yeah. But of course, I think it should be a very good approach.
Thank you, ma'am. And another question from Dr. Mona Vijayan. What is the role of HMA in pediatric MDS patients with IB2 with GATA2 mutation positive with this genetic predisposition?
Well, I think this is a very complicated disease, and probably in this subtype of patients, we proceed to allotransplant. The role of this chemotherapy or this treatment should be avoid if you have the opportunity to move to allotransplant, because this situation is a very high risk disease, and I think that you should move to a curative approach if possible. Yeah, and this in this bone marrow failure syndromes, the use of hypomethylating agents is very difficult due to the hematological toxicity, and I think it's more reasonable, if possible, to move to allotransplant.
Thank you, ma'am. Agarwal sir.
Yeah. Any significance of FLT3 positivity in MDS vis-a-vis AML patients? The same significance and the same action, or any difference?
Yes, I think the same significance of this mutant protein as AML. If you identify any patient with this, you should move to an approach for intensive chemotherapy with FLT3 inhibitors. I think this is the same role, and I think that nowadays the new excuse me, the new WHO classification identify all these patients with these mutant genes as AML, and you should move to this approach. It's also common with ADH mutation. It's not frequent, but sometimes these are present, and probably you should try to move to target therapy like in AML. Yeah.
Thank you.
Thank you, sir. Another question from Dr. Shirok J. What's your take on steroids, danazol in low-risk MDS? Again, the repeat question. Any of danazol we use? Because we frequently use it.
Yes, in Spain it's not very common. I know that in several countries the use of this compound is possible, but we generally don't use. I think if you don't have any other option and no other novel therapies, or even if the patient had failed, probably it should be an option, because it's not toxic for the patient. So probably you can use, but we don't have this experience, at least in my country or in Europe. It's not approval, and we don't use it. I think that colleagues of Latin America are also using sometimes this compound, and I think this should be of interest. And of course, I always say that if there is an option for the patient and it's not toxic, you should try. If you don't have any other, because the majority of the options should be even better than transfusion, because transfusion are the bad thing for the patient. So move on. Yeah.
Thank you, ma'am. Another question from Dr. Vinayak Chikodi. In megakaryocytes, if you see the megakaryocytes as hypogranular and hypolobulated, are the telltale sign for MDS?
The morphology, regarding the morphology. Yeah.
Yeah, the megakaryocytes,
Yes.
hypolobated and hypogranular.
Yes, it's a feature that identify different dysplasia features in this setting. But I think that you have to take into account the whole bone marrow, because sometimes these features are combining other malignancies, myeloid malignancies. So you have to identify other characteristics in the patients, cytopenias, karyotypic, and this is one feature, but you have to take all the features in context in order to address the correct diagnosis, because megakaryocytes alone is sometimes presenting in different hematological malignancies. So we have to take care. In Spain, we have conducted a clinical experience with the micro megakaryocytes, and it seems that generally are associated with MDS, but it depends. It's always controversial due to the identification of this type of cell, and sometimes it's not evaluated in other malignancies. So I think that we only morphologically, you have to always take care with the diagnosis.
Thank you, ma'am. And another question from Dr. Sherrock. What is the conditioning you use for allotransplant in MDS?
The condition in
The
conditioning regimen. Yes, generally we should move to non-myeloablative regimen, because the majority of our patients are older, and we don't use myeloablative conditioning regimen, and we used to use fludarabine busulfan generally in this subset of patients with this non-ablative regimen.
True. And another last repeat question, the rest all are the common repeat questions from Dr. Priyanka. Patient not responding to EPO as well as azacitidine or dasatinib, can we go straight away to transplant?
Well, this is based on the patient's characteristics and even transfusion burden. After these treatments, probably the patient should move to allotransplant, but you have to take into account that sometimes allotransplant decrease quality of life and also mortality, increases mortality. So it's difficult. You have to evaluate very clearly and with caution each patient, this patient, and if, of course, if it's in a high transfusion burden with no other option and bad iron overload situation, probably we should move to allotransplant, but sometimes it's difficult. I have a young patient dying for allotransplant of 35 years old, and I was always worried about this situation, because sometimes if I didn't transplant her, she could be still alive, and it's a difficult situation, only based on transfusion dependency. Yeah.
Thank you, ma'am. Sir?
Just going back to micromegakaryocytes, are they of prognostic significance?
It seems that they are associated with poor prognosis, and probably it could be identified based on a poor genetically disease, based on the presence of altered genes in. I can't remember exactly the gene, but is based on the presence of adverse genes that induce the micromegakaryocyte phenotypic change and is associated to poor prognosis. I think this is nowadays a line of investigation based on this feature of interest, and I think that it could be very promising. Yeah.
Thank you.
Thank you, sir. One new question from Dr. Mona Vijayan. If a patient is intermediate risk as per IPSS-R, but high risk as per IPSS-M, how would you proceed?
Well, I think that this is a very difficult question because sometimes we have this situation, and I think that probably in my experience, it depends on the characteristics of the patients and the disease. If the patient is, of course, in a excess of blast or adverse cytogenetic also, probably I move to treat with allotransplant if possible. And if the patient is not candidate to allotransplant, probably we should start azacitidine based on this molecular risk. But it depends, of course, of the characteristic of the disease. If the patient presented with severe cytopenias or an increased blast count, I move to treatment. But it is only a mild disease. Probably I will wait and see very carefully until disease progression in order to start the treatment. Because sometimes if the patient, especially in patients with a symptomatic disease, non-transfusion dependency, no relevant cytopenias, you can make a change of a few months until the initiation of the treatment. So I think it depends of the disease and the characteristics and the need to treatment. Probably is to be a patient to be very with a follow-up very carefully to follow up the patient and start as soon as possible the treatment.
Thank you, ma'am. Sir?
Do you repeat NGS panel anytime after the diagnosis except for assessing the response to treatment?
Generally, we used to repeat the NGS panel when the patient progress to a other situation. Yes, if he's in a lower risk disease and progress to a higher risk disease, or if he's in a high risk disease and progress to AML, we used to repeat the AML, the NGS panel. And sometimes in patients within the lower risk setting, we used to reevaluate, especially in those in the asymptomatic phase with no treatment. We used to repeat bone marrow after 1 or 2 years. And in this evaluation, we used to repeat NGS in order to address if the patients had clonal evolution.
Thank you.
Thank you, sir. So there are no more questions from the audience. Any discussants want to ask any other question? Okay. So that brings us to the end of this. Well, ma'am, thank you so much for that wonderful lecture and wonderful discussion. You solved so many doubts of us. So patiently answered all the questions. Thank you so much, ma'am, for being over here today, this Sunday. And I now request Zydus to give the final vote of thanks.
Thank you. I'd like to say thank you very much for your kind invitation and to participate in your amazing meeting. Thank you very much.
Thank you. Thank you, Dr. Maria Diaz Campello, for sparing your valuable time. It was a wonderfully crafted, very lucid presentation and followed by a great interactive session. On behalf of Zydus, I thank Mumbai Hematology Group, Dr. M.D. Agarwal, for providing us this wonderful platform and opportunity and making us a part of this esteemed academic discussion. I also thank our chief guest for the day, Dr. Riaz Ahmed, all the discussants and participants who have joined us for this webinar. Special thanks to Dr. Amit Khurana for navigating the entire webinar in a highly proficient manner. Last but not the least, the series of webinar is possible only because of continuous support from Perfect Square team. So thank you so much, everybody, and have a wonderful Sunday.
Thank you, Mr. Sumit, for supporting us. And on behalf of MHG, Dr. Maria, you spared your 2 hours today of deliberation and background work. Extremely grateful to you. It was tremendous learning. Thank you.
Thank you. Thank you very much. It's my pleasure. Have a nice Sunday.
Bye. Bye.
Thank you. Bye.